Hello, ladies and gentlemen. My name is Dr. Mo, Associate Specialist in Medicine. Today, I am presenting Re-Audit Delirium among inpatients, NICE Clinical Guideline 103. Background. Delirium is a common clinical syndrome characterized by disturbed consciousness, cognitive function, or perception, which has an acute onset and fluctuating course. It usually develops over 1 to 2 days. It is a serious condition that is associated with poor outcomes. However, it can be prevented and treated if dealt with urgently. Older people and people with dementia, severe illness, or a hip fracture are more at risk of delirium. The prevalence of delirium in people on medical wards in hospital is between around 20% to 30%, and between 10% to 50% of people developed delirium post-surgery. In long-term care, the prevalence is under 20%, but reporting of delirium is poor in the UK, indicating that awareness and reporting procedures need to be improved. NICE guidance also highlighted the burden of delirium. The patients with delirium need to stay longer in hospital or in critical care. They have an increased incidence of dementia. They have more hospital-acquired complications such as falls and pressure sores. The increased risk of admission to long-term care if they are in hospital. And finally, the increased risk of dying. Aims and objectives. The aims of this re-audit are to assess if, number one, patients with delirium are identified and managed as per NICE guidance. Number two, patients are referred to GP and mental health services at discharge. Standards. The standards were based on NICE guidance, delirium diagnosis, prevention and treatment, updated in March 2019. The table showed the criteria and standards used for this re-audit. 4 criteria and standards were used. Number 1, obtain valid confusion capacity screen on admission. Number 2, Tracer check for polypharmacies or drugs worsening delirium. Number 3, infection screen in delirium patients. Number 4, in patients not attaining baseline mental status on discharge, refer to GP or mental health team is completed, unless patients already known to these services. Sample. This was a retrospective study. All inpatients over the age of 65 years with delirium coding, that is F05, were included in this study. The coding department provided list of patients with delirium between July 2018 and July 2019 inclusive. Associate specialists designed the initial Excel spreadsheet for data entry as per the NICE guidance. 2 specialty doctors reviewed the EPR, electronic patient record entries, during the audit period individually. Cognitive assessment, that is abbreviated mental test AMT, was also obtained from Synopsys Digital Pre-Op and OT notes. The OT notes will be available in Pathway Nursing Cadets Track Chart folders on the EPR. The data was entered into the Microsoft Excel spreadsheet, random sample of which was later checked by the associate specialist. The report and action plan was written by associate specialist, which was further reviewed by another associate specialist and consultant physician. Discussion and analysis. Total 23 patients were eligible for the present study. 11 patients were male and 12 patients were female. (82.6%), that is 19 out of total 23 patients in this study were 75 years and above. 17.4%, that is 4 out of total 23 patients were younger than 75-year-old. Documentation of AMT for all patients on admission was done in 69.5%, that is 16 out of 23 patients. This figure was improved from 50% in previous 2017 audit. This slide shows AMT documentation on patients with 75 and above. Here, I like to mention about the discrepancies in the age cutoff for doing confusion dementia screening between the trust pre-op clinic, in which we use the patients with 75 and above, and NICE guidelines, which used 65 and above. 15 out of 90 patients who were 75 and above had AMT done, but 4 patients refused to get AMT assessment at pre-op clinic. So 100%, that is 15 out of 15 who gave consent for baseline AMT assessment were done. This figure has improved from 69.2% in previous 2017 audit. Next slide shows structure check for polypharmacies or drugs precipitating delirium, which has completed in 91.3%, that is 21 out of 23 patients. Structure check was not well documented on EPR in most of the patients, but it can be indirectly known by the other documentations on EPR, such as the documentation of possible causes of delirium and management plans, which included to omit some medications or to prescribe antibiotic or PRN medications, as well as by reviewing drug charts which are uploaded on the EPR. Next slide. Infection screen in delirium patients was done for all 100% patients. 16 out of 23 patients, 69.5% delirium had resolved on discharge. 7 out of 23 patients, that is 31.5%, did not completely return back to their baseline mental status on discharge. 3 out of 7 such patients, that is 42.8%, who did not return their baseline mental status were informed to their GP on discharge. Of the remaining 4 patients, 1 patient was discharged to nursing home, who had been diagnosed as dementia and known to mental service team at previous hospital. 1 patient was transferred to Royal Shrewsbury Hospital after an eyewitness fall with relevant information. One patient was discharged to community hospital with relevant information for rehabilitation, and one patient passed away during hospital stay at our hospital RGAH. So we will say 100%, 3 out of 3 patients who did not completely return back to their baseline mental status on discharge back home were informed to their GP on discharge letters. The next slide. This is a summary table of our audit's result. Conclusion. Confusion dementia screen was done in the majority of the patients with 75 years and above, especially for patients from medical wards, which is an improvement compared to previous audit in 2017. All patients suspicious of having an infection was screened for any possible infection and sepsis. Documentation was inadequate regarding stretcher check in many patients. The condition for the majority of patients improved to the baseline on discharge. The patients who did not attain baselines mental status either died in hospital or they were transferred to RSH or another community hospital. Recommendations. All patients with 75 years and above of age should have AMT test done on admission. Patients with confusion should be screened for delirium with screening tools like CAAW, Confusion Assessment Method. All patients with delirium should have the documentation of stretcher check on EPR. Polypharmacy should be actively sought and the precipitating medications stopped. GPs should be informed about delirium with a view to consider referring to mental health team. So, 3 review methods will be used. Number 1, to email to all doctors, that is medical, spinal and orthopedic doctors, about our audit findings and action plans. Number 2, to present these re-audit findings and action plan at medical lunchtime meeting. And number 3, to do the re-audit in 2 years' time. Thank you.